So this is a one-eyed patient with an extremely dense nuclear cataract, reddish. She's had recurrent corneal abrasion. You can see the epithelium right there was kind of loose. I just patted it down. So at the end we'll put a bandage contact lens on her to protect that area. Her other eye was enucleated after trauma. So this is her only seeing eye. And she's 66 years old. So there's our side port incision, followed by our 2.4 clear corneal keratome incision. And we're going to stain this capsule. Because the red reflex isn't so terrific. Going to feel a little sting for a few seconds, not bad. Intraocular lidocaine. Everything's fine. You just keep looking straight ahead. And now comes the viscoat injected distal to the air bubble to expel it. And that's a lot of viscoat because there'll be a fair amount of phaco done here and protect your endothelium with the dispersive OVD. Can't miss the opening there, made with that sharp 25 gauge needle. Wet the cornea, please. Good. So now the capsulorhexis. And in very dense lenses, I'll usually make a little bit larger capsulorhexis. So I'll take it out to where I want it and now follow the curve of the pupillary margin. And temporally I might not go out quite as far. And there we go. We'll start off the phaco after the hydrodissection and viscodissection with 60% power in the balanced tip. But we'll often, on such a lens as this, increase it to 80%, rarely to 100%. 100% usually required for some black nuclei. So that's viscodissection. And now the subincisional viscodissection. So we essentially have a nuclear sandwich. You notice that her epithelium dries out easily, so we'll be keeping that moist. Testing infusion capacity. And it's now satisfactory. So the first thing about dealing with a dense nucleus of this nature is patience. It's going to take several minutes to get this nucleus out. So I have the chopper out over the equator. I have the eye a little bit rotated toward me. Wet the cornea. Good. Now we don't really expect to get a red reflex here unless we get super thin. So I'm just kind of looking at the lay of the land, the rhexis, wet the cornea. And I have to be pretty vertical with this phaco tip. You know, a balanced tip is pretty much a straight tip. It's no angulated Kelman tip. And wet the cornea. Those little bubbles were bugging me, so I just went up there and aspirated them.
It's hurting.
So I just did an impale partial chop there. Wanted to just test the waters. Now I'm going to sculpt a little wider and go deeper. So you can see that it's chopping into the center. It's not going to propagate all the way across. So let's rotate this nucleus, wet the cornea. And now let's go in the other direction. Now we may have two heminuclei here, I think we do. So now we're going to rotate and divide the hemis. Wet the cornea. That was a 3 to 2, meaning foot pedal went from 3 to 2. Quadrant removal. Back to sculpt. So that was a nice chop there. Notice how the chopper kind of slipped on top of the bag there for a second, but I was watching for that. So I just repositioned it. Okay, quadrant removal. I want to get one of these quadrants loose and get it to come up here, but haven't yet. So I'm going to go right back to the center here, sculpt. And remove some of the central impediment to mobilizing them. You can see that they're separated. There was a little isthmus right there that we just took care of. Quadrant removal. And I want to chop this piece. Sculpt. And quadrant. You know, one-eyed people, they just tend to wait. Maybe not quite as long as this one to get as dense as this one, but they're usually going to be a pretty significant cataract. I'm just going to stay on top of this for a while rather than go right through it. So this, maybe 40% of the lens remaining here, still kind of adherent together. So let's see if we can't do something like that and get it to separate. Okay, so now I think we're going to increase our power a little bit for the remaining dense part. So we're going to now go to procedure 2. which is actually 85% on power. You know, if there's a real key to doing these, it's patience. You just don't charge through them. You tell yourself at the beginning they're going to take longer. And then whatever it takes. What the cornea? I mean, when you consider that some neurosurgical procedures take 12 hours. It's not a lot of time to spend 5 or 7 minutes, whatever it takes, to remove one of these. And I think that's the way you have to look at it. I'm going to reposition this, keeping the chopper protecting capsule. Now there's almost never much cortex left in these eyes because it's all become nucleus essentially.
Procedure 1. Cortex.
So here we go for cortex removal. Almost all of these really dense nuclei have a lax zonule. So you want to watch out for that. And you especially want to watch out for that during cortex removal. So I'm just holding the posterior capsule posteriorly. Especially when I go subincisional. What the cornea? And I really want to get my best mechanical advantage and just feather the petal and tease out the cortex here. Got a little bit left, and I think I can get that in just a second by turning this way. What the cornea? There we go, ready for IOL insertion. This is a Monarch D cartridge. And we put that trailing optic and haptic in before the entire lens unfolds. That makes it much easier. So we want to be ready with that second instrument as we insert it. And now we'll remove the OVD first from behind and then in front. Now, if this lens were a little bit more dense, like into the black, it would have been unchoppable. And we would have had to go to a more laborious, and this one was laborious enough, but a more laborious divide and conquer. But we didn't have to. So much more sculpting is required. Last, still our basic principles apply. Irrigate the angle. A little pressure now.
Oh, it hurts.
It'll stop in a second. Just shows you I got the IOP up. It's gone now, huh? You okay now?
Yeah, I'm okay.
Yeah. That's okay. I just raised the pressure for a moment, and that's why you felt it.
All right.
And I'm now lowering her IOP in little aliquots here.
Oh,
Good. Yeah, we're now down around 20-ish, and that's where we'll leave her. You can see the emulsate on the hyaloid face, and that's of no consequence, of course. And last, we're going to place the bandage contact lens on the eye because we saw the loose epithelium there, And if we don't, there's a good chance that the minor trauma of this procedure could give her a corneal abrasion overnight and a lot of discomfort. There we have a reddish brunescent dense nucleus in a one-eyed patient. The steps we have to take to carefully remove that nucleus.